Okay, okay. Hi, hi.
Hi, everyone. Thank you for joining. We are going to give everyone a few minutes to join and then we will get started. Hi all, thank you for joining us for this Gradient Health Systems webinar. Before we get started, my name is Miriam Khan. I lead communications for Gradient Health Systems. I just wanted to walk you through a few housekeeping pieces, and then I will turn it over to our moderator, Dr. Papicho, who will introduce our panelists and a bit about the topic. So if you have any questions during the webinar, please use the Q&A function at the bottom of your screen to ask any questions. We will save time at the end to answer them. If you have any issues with connection or audio, please use the chat function as well to let us know. The webinar will be recorded and you'll receive a copy of the recording after the webinar to your email. If you don't receive it for some reason, you can access it on our website at gradienthealth.org under the training page, as well as on our YouTube page. And if you have any questions after the webinar, if we weren't able to get to your questions, or if you have any feedback on topics you'd like to see included, please email us at customers@gradienthealth.org. We are always looking for feedback and how we can improve, so please feel free to share your thoughts. I'll now turn it over to our moderator, Dr. Papicho, who will go over the objectives and introduce our panelists as well.
Hi, everyone, and welcome to this webinar. As usual, today we'll be discussing this important topic with regard to anesthesia. We understand it's one of the challenging situation to encounter with when you are in the operating room. So, of course, there are some changes on the moderator. My name is Anesthetic and I'm from Tanzania. I'll be moderating this session, and Dr. Papicho and Dr. Ndaba from Zambia, they'll be panelists. So today we are blessed to have two presenters, one from Tanzania, Dr. Victoria Dominican, and Dr. Ahmed from Nigeria. So they will take us through the following objectives. So we discuss a little bit of the pathophysiology, and actually aiming is to understand the aim of perioperative management when you are preparing this patient. But also we discuss some complications which we understand a bit comes with some complications, which we, some of them you have to understand them so that you can classify a patient accordingly. We'll go on to discuss some perioperative assessment for this patient. And then once we've done that, we'll go in and discuss some general principle, especially on anesthetic considerations and the do and don'ts. And then we'll touch a little bit on the regional anesthesia, specifically what are the advantages and actually what are the considerations when it comes to diabetic patient. And we all understand LS is the coming up area, and we will see how does this patient fare where in the LS. So we all discuss a bit of the LS in this patient. So this webinar is divided in two parts, where the first part will be done by Dr. Mohammed. So I will welcome Dr. Ahmed to start the first part. But also, if you have a question, as it was said, you can write it in the Q&A questions, and we'll have some time for question at the end. But we understand time might not be enough for the last part. So if you have a question, please write it in the Q&A box, and then we will reply as we are continuing with the panel. So I will welcome Dr. Mohammed to start the first part. Once again, welcome so much.
Hello. As you have seen, my name is Dr. Abdullahi Mustafa Miko. I'm an anesthesiologist. I'm from Nigeria. I work Next slide. I would like to talk about the overview of diabetes mellitus as depicted by the next slide, please. So diabetes mellitus is a complex disorder that is characterized by hyperglycemia. This hyperglycemia can lead to severe metabolic, which is not only limited to that, but also including death. The WHO and the Pan-American Health estimated approximately 537 million people worldwide to have diabetes, with a projected increase to 700 million by the year 2045. Diabetes is estimated to contribute to 11.3% of death globally. This is by WHO. Approximately 1 in 11 adults in Europe have diabetic mellitus, making it the second most common perioperative comorbidity there. Diabetes mellitus is frequently encountered preoperatively, and operations in patients with diabetic mellitus account for up to about 50% of patients with diabetes will require a surgical procedure during their lifetime. Next slide, please. Surgical intervention are often necessary to these patients. So we need to optimize the patient before the onset of anesthesia. So optimum anesthesia management in this population is crucial for good outcome. Effective anesthesia management of diabetes necessitates an understanding of the physiological changes associated with diabetes, while we should also anticipate potential complication and the strategy to optimize perioperative care. Diabetes affects various organs and systems, potentially influencing the response to anesthesia by altering the autonomic dysfunction, impairment of cardiovascular function, and even impairment of drug metabolism. Hyperglycemia often also leads to electrolyte imbalance, reduced wound healing, increased risks of wound infection, and increased wound infection. Next slide, please. Through the period, it's crucial to evaluate the patient glycemic control, organ function, and any diabetic-related complications. Preoperative screening for comorbidities such as hypertension, neuropathy, nephropathy can guide anesthetic decision, as these are some of the target organs, the heart, and then we can have some peripheral neuropathy, among other complications. Optimal preoperative glycemic control is essential to minimize risk and improve outcome. Effective management in anesthesia of diabetic patients requires a comprehensive and multidisciplinary approach. So we have to put our hands together between the surgeons, the anesthetists, and the physicians, endocrinologists in particular, to have a good approach to optimize patients. Next slide, please. This is the diagram showing the types of diabetes mellitus. Type 1 commonly seen in children and account for 5 to 10% of diabetes, and is characterized by autoimmune destruction of the pancreatic beta cells. The type 2 diabetes mellitus commonly seen in adults and account for up to 95% of diabetes, characterized by insulin resistance and deficiency. In pregnancy, we can have gestational diabetes, which complicates about 1 to 14% of all pregnancy, and usually occurs at the second or third trimester. Secondary diabetes can be due to the diseases like polycystic ovarian diseases, or we can have it in pancreatic tumor that secretes glucagon, that glucagonoma, or we can have it even in patients with these other endocrine disorders. Next slide, please. And when we have we can see the pancreas and the liver, and then we can see the diagram. The pancreas secretes the hormone glucagon when there is a low blood sugar, and then this glucagon now stimulates glycogen breakdown, which now increases the blood glucose level. And on the other hand, if the blood glucose is high, then insulin will be secreted, which now stimulates the glucose uptake from the blood and utilization in tissue, and now reduces the blood sugar. As well, the insulin also stimulates glycogen formation, which also reduces the blood sugar. The other functions of the insulin is secreted by the beta cells of the pancreas and exactly the following physiological effect we just said: uptake and utilization by tissue. That is one of the effects, and it affects glucogenesis, lipogenesis. It inhibits gluconeogenesis, protein synthesis, and inhibits glucagon secretion. So it regulates the blood glucose by bringing it lower to a lower level. Next slide, please. So this is another diagram depicting how hyperglycemia is coming. We can have it from the brain that is affecting the satiety, and then somebody will have hyperglycemia by increasing the intake. And then in the liver, we can have gluconeogenesis, which increases the glucose and giving us hyperglycemia. And the pancreas, we can have decrease in either insulin secretions, which now will now reduce the utilization of glucose, and again glucagon secretions, which increases the production of glucose. So you can have hyperglycemia. In the intestine, the glycoprotein secretion is decreased, so we can have hyperglycemia as well. In the kidney, the absorption can increase, and there is also control of gluconeogenesis by the kidney, so also it can give us this hyperglycemia. The fat, there is increase in free fatty acid, adiponectin, and inflammatory cytokines can all give us this. So lack of insulin action at the tissue level leads to the impairment of glucose uptake and utilization in various organs, leading to hyperglycemia. Chronic hyperglycemia accounts for numerous complications associated with diabetes mellitus. Next slide, please. Another diagram also showing the hyperglycemia, just what we just discussed a little bit. So we can see now the liver, we can have the glucose output and glucogenolysis that give us the hyperglycemia. We can have intravenous glucose when we give can increase the blood glucose level, corticoids. We can have catecholamines during surgery. Also, can just get response to catecholamines increases glucose level, causing hyperglycemia. Inflammatory cytokines and parenteral nutrition, enteral nutrition, when given in a higher dose, can give us hyperglycemia. This hyperglycemia, when present, can give us circulatory and electrolyte effect. We can have volume depletion, hypoperfusion, electrolyte loss, acid-base disturbance. Due to this, we can have sepsis, multi-organ failure, including death. At the tissue level, we can have reduced nitric oxide, superoxide generation, endothelial dysfunction, platelet activation, immune dysregulation, mitochondrial injury, as well also will now give us this sepsis, multi-organ failure, and death. Utilization we have discussed, but you can see that there is a decreased utilization by the muscle can give us increase in glucose leading to hyperglycemia. Thank you. Next slide, please. The major complication of diabetes, if we can take it, we can have one at affecting the vessels. We can have diabetic angiopathy with angiopathy, nephropathy affecting the kidney, retinopathy affecting the eyes, the retina, angiopathy of the lower extremities. And then we can have the macroangiopathy, which can affect the heart, brain, and as well the lower extremities. Diabetic neuropathy can be central and can give us diabetic encephalopathy in serious cases, and can be peripheral and can be visceral, dysfunction of the inner organs. This is a schematic representation here where we have the nephropathy, where the heart muscle is attacked. We have coronary heart disease in the legs. We can have ulceration. We can have diabetic foot, which can lead to amputation of the leg, part of it, or even you can go a bit higher. Next slide, please. Preoperative challenges. What are these challenges that we have during the preoperative period? As we said, we can have sepsis. When you have sepsis, you can have dehydration, acid base, and electrolyte disturbances. These patients are commonly associated. Diabetic patient can be having associated hypertension, anemia. We may require multiple surgery, e.g. The thing is, I can't get it right. Maybe one of the panelists will assist me in getting it right. And then you can usually have elderly patients. So with dehydration, when you are coming to use okay, I think this one will be discussed in the anesthetic management, but hydration, they have to be hydrated, and then the acid-base balance has to be corrected. And patient with hypertension, when you are going to take that patient, you have to take precautions during the intubation, even the preoperative preparation, to prevent untoward effect. Anemia has to be corrected so as to enhance the hemoglobin carrying capacity and oxygen utilization. Poorly control hyperglycemia, and then sometimes we don't have standardized starvation time, and then patient may have associated cardiac lesion apart from what is presenting with the diabetes. And then we have risk of gangrene at any time, in the risk of theater contamination, because some patient can come with diabetic food which is infected. And just for having the diabetes, the American Society of Anesthesiology score is increased. Thank you. Next slide, please. Other intraoperative challenges also is dehydration, because when you have hyperglycemia, there are going to be dehydration because of loss of water. And then we can have arrhythmias. We can have poor monitoring during the surgery. And then we don't have sometimes standardized intraoperative diabetic management protocol in most of our hospitals. And then if care is not taken, we can have risks of hypoglycemia. That is why sometimes some institutions use insulin potassium solution with dextrose so as to prevent hyperglycemia. Hypotension can come due to severe dehydration or autonomic dysfunction. Thank you. Next slide, please. Other challenges could be post-operative, because they are prone to infection, they are prone to anemia, and then we have problem with glucose control. Due to this incidences of infection, higher infection rate in diabetic patient, we can have a poor wound healing, and then there is a risk of repeated surgeries in these patients. Next slide, please. The anesthetic and surgical outcome for diabetics. Patients with diabetes may also be at a higher risk of adverse effect when undergoing surgery because they have a higher ASA score. It is estimated that more than half of the diabetics, so about 50% of the population, will require surgical intervention during their lifetime. Hyperglycemia and hypoglycemia and large glycemic variability all aggravate the disease states of the patient and increase the incidence of surgically related adverse effects. Hyperglycemia is also a risk factor for post-operative sepsis, endothelial dysfunction, cerebral ischemia due to angiopathy, and poor wound healing. The wound healing can also be due to the angiopathy or due to the rate of infection that we can have. Next slide, please. Stress due to trauma, operative blood loss, and intraoperative glucose level in diabetic patients due to the stress response to surgery. Reduce diabetic emergency, including ketoacidosis, hyperglycemic, hyperosmolar syndrome. Secretion of stress hormones such as steroids with hyperglycemia. This will provoke water, electrolyte, and acid-base imbalances. Post-operative complications, lengthen hospital stay, increase the economic burden. Next slide, please. This is the graphic. This is the of the diabetics complication post-operatively. The delayed extubation having the highest incidence, and then circulatory abnormalities, then circulatory disorders and infection of other, followed by non-healing of the incision site. Other complications are also death occur in about 3% of the patients, about 3% of patients. Next slide, please. Thank you very much for listening, and then the other panelists will take the next session. Zoom. Thank you very much.
So thank you very much, Dr. Mohammed from Nigeria, for such a wonderful presentation, elaborative, and actually was loud and clear. So I will welcome Dr. Victoria Adomikam from Tanzania to take us through the second part. Dr. Victoria, please, the floor is yours.
Thank you, Dr. Sweetbet. Thank you, Dr. Mohammed, for a thorough review of diabetes mellitus and anesthesia, science and the principles. Can I get the next slide, please? And the next one. Now that we do know the principles and we have our patient who is diabetic, let's see how we can apply these principles perioperatively. To start with perioperative assessment, the foundation of the perioperative assessment is a comprehensive history and physical examination of the patients. There's a number of informations that we'll have to collect. There are a number of signs and symptoms that have to be identified early. We shall see them in the coming slides. During your preoperative assessment, it is important to look for the signs of autonomic neuropathy, which has a great significance during anesthesia. we should be able to identify the stiff joint syndrome during the physical assessment time. Next slide, please. So to start with history, what I usually say, the first thing when you are going to get the history from a diabetic patient coming for surgery, the first thing would be to obtain the diabetes history. That is, you need to know what type of diabetes do they have. Do they have type 1 diabetes or type 2? Duration of the illness, how long have they been sick? A patient with diabetes for 1 year will not have the same complication as the one who has had diabetes for, let's say, 10 years. So that should be noted early. What type of management are they on? Are they on lifestyle modification? Are they on medications? And if they're on medications, what type of medication are they on? Are they on insulin? Are they on oral hypoglycemic? After identifying the medications, you can go further to knowing the dose that they have on. A higher dose can indicate that there has been a problem with blood glucose control. The frequency of the medications, and also the patient's adherence to their medication. And lastly, if you can obtain during history blood sugar control, that should be obtained very early on. We should be able to identify the nutritional, exercise, and weight patterns of your particular patients. We should be able to obtain alcohol, tobacco, and other substance use. Now, since we have seen that diabetes affects almost every organ in the body, we should be able to do a multi-organ assessment. That means starting from cardiovascular assessment, respiratory, CNS, in every system. So for instance, in the cardiovascular system, we know they are prone to ischemic heart diseases, coronary artery diseases, hypertension, ischemia may be silent. So it is important to elicit the signs and symptoms that are suggestive of these conditions. In the respiratory systems, we know diabetics are prone to respiratory infections, and even more if your diabetic patient is smoking and they are obese. So we should be able to get these symptoms earlier on. In the central nervous system, they are prone to neuropathies. One of the most important neuropathy that we should identify early during history taking is autonomic neuropathy. So we should ask for symptoms like dry eyes, dry mouth, abnormal sweating. If the patient has orthostatic intolerance, they have bowel incontinence, they have sexual dysfunction, presence of these symptoms should alert you that there is a possibility of an autonomic dysfunction. If they have peripheral neuropathies, ask if they have numbness, they have tingling in the tingling sensation in the hands and feet. If they do, it should notify you that they do have peripheral neuropathy, and you should consider appropriate positioning when you're planning for your intra-op management. Consider appropriate positioning and extra padding in such a patient. In the GI, diabetics are prone to delayed gastric emptying, so they have a risk of aspiration. So ask if they have history of reflux symptoms. In the immune system, we know they're prone to infections, so it is important to know if they have any history of fevers. When you're doing your inspection, don't forget to inspect their feet. For a patient who is coming for, let's say, a thyroidectomy surgery, they might not think their diabetic foot is a concern. So for you as an anesthesia care provider, you should be able to inspect and make sure that you note if they have or they do not have diabetic foot. During physical examination, record all the vitals that you get during preoperative assessment. Do all the orthostatic measurements. Fundoscopy, if it is not done, it should be done earlier on. In the airway, these patients have a risk of stiff cervical joints. So it is important to be able to do examinations that will help you to know whether they have a stiff or not stiff cervical joints. So one of the simple signs that can be, simple examination that can be done is the prayer sign, where you will ask your patient to bring both of their palms together as if they're praying, and ask them to extend the wrist at least 90 degrees. And if both sides of the palm cannot touch each other, that is called a positive prayer sign. And this indicates stiff cervical joints, which would mean that you might have difficulties with laryngoscopy because you won't be able to manipulate the neck so much. Other examination will depend on how the history comes about. After physical examination and history, we'll go the next step, which will be investigations. Routine investigations for diabetic patients include full blood picture, getting your random blood glucose, getting the ketones. Because we know diabetes can involve the kidney, urea and creatinine should also be done before surgery, as well as electrolytes. For the risk of silent MI, ECG is also a routine investigation for them. Other investigation will really depend on history and examination. Next slide, please. So then after getting your history, physical examination, and doing your investigation, the next thing would be to optimize your patient. So the general aim here is to minimize occurrence of hypoglycemia and incidence of excessive hyperglycemia. Now, when optimizing your diabetic patient, there are three things that we usually look at. That is the type of diabetes, whether they're type 1 or type 2, the type of medication that they are on, whether it's insulin or oral hypoglycemics, and the type of surgery that they are going for, whether it's minor or major surgery. Now, if your patient has type 2 diabetes, they're not on insulin, and they are going for a minor surgery, let's say a dental extraction, examination and anesthesia, or biopsy, or they're coming for a biopsy. These ones, they can go on without insulin and they may be fine. But if it occurs that your patient is going for major surgery, or they have a poor glycemic control, these ones should be started on insulin therapy before surgery. And when you are starting the insulin therapy, it should be a continuous infusion, since you can have a better control of blood sugar as compared to when you're using subcutaneous or intermittent bolus. Next slide, please. Now, during preoperative fasting, especially for our diabetic patients, there is an increased risk of hypoglycemia and excessive catabolism. So to avoid all that, parenteral administration of carbohydrate is required preoperatively. Now, back to insulin infusion protocols. There are a number of insulin infusion protocols that can be used preoperatively, but here we shall discuss only one. Next slide, please. We shall discuss one regimen, that is the Alberti regimen, that has been shown to be a simple, safe, and effective therapy. This therapy involves using glucose, insulin, and potassium in the same solution. And so, for instance, here it is written that you'll take your 500 mils of 10% glucose and then add in 16 international units of soluble insulin and 20 milliequivalents of potassium. And this should be started depending on the level of blood sugar by the time you're going for surgery. It should be at least started 1 hour prior to surgery, and it should be continued again at least after one hour after the patient has taken their first meal. So if you do, here we have used 500 mils of 10% glucose. If you do not want to use a large volume of free water, you can go with 50% glucose. So there you will add 0.25 or 0.5 units of insulin per each meal. Next slide, please. Now, before discussing this slide, we shall share with you another article that is on optimization of oral hypoglycemics. There's almost all the drugs, but I'll just mention 2 drugs that are commonly used in our settings, that is metformin and sulfonylurea, like glibenclamide. So previously, we used to omit metformin on the day of surgery, in the morning of surgery, due to the risk of acidosis. But it has been shown that the risk of acidosis is not as great as it was. So the current evidence suggests that if the patient is taking metformin and they're coming for surgery early in the morning, so the morning of surgery, metformin can be taken as normal. Sulfonylureas will be omitted on the day of surgery, especially if they are doing a once daily dose. And that once daily dose is taken in the morning, sulfonylureas should be omitted. And also, if they're doing twice daily dosing, you should omit the morning dose of sulfonylureas. Okay. Now, what are the metabolic challenges that the diabetic surgical patient will face? There are a number of challenges. One of the immediate ones are stress response following surgical procedures. Here we see the following surgery, there will be secretion of catabolic hormones. These include catecholamines, cortisol, growth hormone, and sometimes glucagon. These hormones in general are hyperglycemic, so they'll cause increased glucose levels. And 2, we know that they have an anti-insulin activity. And as a result, the requirements for glucose and insulin will become very unpredictable for these patients. This means that we should do close monitoring of blood glucose, especially if these patients are unconscious. That is, they are either sedated or they are under general anesthesia. Another metabolic challenge is interruption of food intake. This will put them into an increased risk of hypoglycemia, as well as dehydration and electrolyte imbalances. Another challenge is altered CNS, which will mask symptoms of hyperglycemia if they're there. So here we should be able to check glucose level repetitively. And another complication are circulatory disturbances that are associated with anesthesia and surgery, which will, in the end of the day, alter insulin absorption. Next slide, please. Next slide, please. I think I have already explained this slide. Yes. So the main goal for the anesthesia care providers, as we have said earlier on, is to avoid hypoglycemia and avoid excessive hyperglycemia. So previously, there was this concept of permissive hyperglycemia that was used back then. The reason is probably because they did not have devices or equipment to measure blood glucose, possibly. But recently, because we do have access to point of care devices that can measure blood glucose, and also we have evidence showing good outcome following good glycemic control, this concept of permissive hyperglycemia is no longer acceptable. And thus, the American Diabetic Association do recommend that during the perioperative period, blood glucose should be kept between 80 to 180 milligrams per deciliter, which is equivalent to 4.4 to 10 millimoles per liter. And if your patient is critically ill, blood glucose should be kept between 140 to 180 milligrams per deciliter, which is equivalent to 7.7 to 10 millimoles per liters. If you can do HbA1c, it is good, even though it is just good for long-term glycemic control, but it really does not have value in the perioperative period. Next slide, please. So the goal is to have HbA1c of less than 7%. since having more than 8% is likely that your patient will have microvascular complications. Now, one thing of importance that we have to note here is that if your patient is presenting for elective surgery and they have acute metabolic complications of diabetes, that is DKA, HHS, and the rest, surgery should be postponed until the patient is stable. Next slide. Yeah. So just to remind everyone, the macrovascular and microvascular complications are a special concern to us, especially because these complications have a direct effect on development of perioperative complications. Next slide, please. Okay, now we'll look at anesthetic agents and diabetes. The list is not exhaustive, but we'll just mention few. So starting with etomidate will reduce the level of cortisol, and thus it will decrease hyperglycemic response to surgery. The same with benzodiazepine, even though it's by different mechanisms, but at the end of the day, it will reduce cortisol. Also, we are seeing the same effect with opioids, where with opiates, we see complete abolition of catabolic hormonal responses. The effect of propofol on insulin is not very well known, while that of ketamine, ketamine is associated with hyperglycemia in diabetic patients. Our volatile anesthetics do inhibit response to glucose in a very reversible and dose-dependent manner. Next slide, please. Okay, now, considering everything that we have already discussed, we see that regional anesthesia do confer a number of advantages to diabetic patients, including reduction of stress response to surgery, provision of adequate analgesia, early ambulation and function restoration, which is for every other patient, we know it will reduce the risk of DVTs, but here for diabetic patient, it will also reduce the risk of diabetic foot. Avoidance of GA, considering the risks that go with hypoglycemia and unawareness. It is important to note that these risks and benefits have to be discussed with the patients before they consent for surgery. Also, it is important to adhere to aseptic techniques to all patients, especially when we are going to leave indwelling catheters. An ultrasound is advised rather than anatomical methods or the use of nerve stimulation. And also, if your patient has neuropathy, addition of vasoconstrictors should be avoided. Next slide, please. Yeah, more advantages of regional anesthesia in diabetes patients. In addition to the ones that we have discussed in the previous slide, we see here there's avoidance of loss of airway and avoidance of aspiration. This is because the patient is in control of their own airway. There is reduced risk of postoperative nausea and vomiting when doing regional anesthesia. This is important because there will be a rapid return to a normal diet, as well as resumption of their normal medications. And also we see there is reduced reliance on insulin infusions, especially because the patient is aware, and a lot of symptoms can be elicited when the patient is aware. Next slide, please. And a number of many advantages that we'll share with you and you'll read on your own time, but all these advantages really go back to the last advantage, that is shorter length of hospital stay, which is the thing that we are all aiming at. Next slide, please. So with all these advantages, there are risks that are associated with regional anesthesia in diabetic patients. Number one risk is nerve injury. And this is common, especially if one opts to go with the anatomical identification of the nerves anatomically or the use of nerve stimulation, and thus the importance of an ultrasound. There's a risk of prolonged block, especially if the patient have diabetic neuropathy. And in these scenarios, it is recommended that we do reduce the dose of postoperative analgesia. Another risk is infection, especially spinal and epidural abscesses. So number one, we should do a meticulous aseptic technique, but also we should shorten the duration of catheter treatment and remove them as early as it is feasible. Another risk that is directly to us are medico-legal issues. And so we should do a comprehensive shared decision-making with patients, and we should provide a detailed documentation of everything that we do with these patients. Document everything that you note in the history, and if you know that they had autonomic dysfunction, document it. If you saw that they had peripheral neuropathy, document it, so that at the end of the day, someone does not come and say it was your regional anesthesia which made me lose sensation in my lower limbs. Next slide, please. Next slide. Okay, so the last part that we'll have to discuss today is enhanced recovery after surgery. As Dr. Sweetbet mentioned it earlier, these are evidence-based multimodal protocols that are used to facilitate early recovery after surgery and reduce the rate of complications. Now, before ERAS, all patients were subjected to a period of starvation, and then they would go through surgery, which is a major stress, and then there will be a period of immobilization. The combination of all these things would lead to always result in increased complications. But with ERAS, since ERAS has come up, we have seen impressive patient outcomes. For instance, as you can see in your screen, on the right of your screen, we see a 42% reduction in a 5-year mortality following post-cancer surgery. So this is an impressive findings. Next slide, please. Now, these are the elements that are found in ERAS protocols for every other surgery, or let me say every other patient. There are pre-admission elements like cessation of smoking and excessive intake of alcohol, and then there are pre-operative elements, intraoperative elements, and post-operative elements. Next slide, please, so that we can discuss more of ERAS in diabetes patients. Now, that was ERAS in every other patient. ERAS has been studied in so many patients, and it has been shown to have positive impact. What about DM patients? This study here did compare the outcomes after colorectal surgery between diabetics and non-diabetics, and they concluded that having diabetes mellitus was not associated with longer hospital stay or complications, meaning that whether you have DM or you don't have DM, when the principles of enhanced recovery after surgery are applied, outcomes will be almost the same, and thus ERAS should be our way to go for diabetic patients. Next slide, please. And so these are the elements. Remember, there was a slide for elements of ERAS in every patient. Now, these are the elements particularly for diabetic patients. So preoperatively, we should do a pre-admission counseling, and here we should not forget to involve the family. We should ensure to do a fluid and carbohydrate loading. We should avoid prolonged fasting. we should not do bowel preparation, and if it is necessary, it should be selective bowel preparation. We should ensure antibiotic prophylaxis, thromboprophylaxis, and avoid pre-medication preoperatively. Intraoperatively, we should go for short-acting anesthetic agents, opt for mid-thoracic epidural anesthesia or analgesia. We should avoid drains. We should avoid salt and water overload, and also we should maintain pneumothermia. Postoperatively, we should continue with the mid-thoracic epidural analgesia, but again, avoid nasogastric tubes. Try your level best to prevent PONV. Also avoid salt and water overload. Ensure early removal of catheters if they were inserted. Ensure early starting of oral nutrition. Go for non-opioid oral analgesics. Try your level best to avoid opioid analgesics. And also ensure early mobilization and early stimulation of gut mortality. And equally important, ensure auditing of compliance and outcomes. Next slide, please. So to conclude, we have seen that diabetes is one of the high-risk comorbidity in surgical patients. And so in order to improve surgical outcomes, there should be aggressive perioperative management of diabetic patients. That should be multidisciplinary, and it should be made, and their management should be made on case-by-case basis. Thank you very much. I think this is the last slide. Yes.
Thank you very much, Dr. Victoria, for such well-represented material. I think before I welcome, before opening the floor to questions and answers, I think I would like to welcome one of our senior. Of course, I'm sure there are more seniors, and I apologize if I won't mention you, but at least Kevin Newmani, can you please comment if you have any addition or if you have any suggestion? I would like to welcome you to open the discussion session with your word. Kevin Newmani, please unmute yourself, then you can say something. Our colleague from Kenya. Is he still available? Kevin? I don't think if we still. Okay, is not. Oh, so I will take this opportunity once again to thank you everyone for setting up your time and joining us. And also I'd like to thank presenters for sharing their experience. Actually, it was nice listening to you. So I open the floor for any question. So if you have a question, please unmute yourself or raise your hand, then we will give you opportunity to ask your question. So we have like 10 minutes. We have like 10 minutes for question and answers before we finish up. There's a question in the chat from Belema Oduma. I will leave the way it is. Thank you for your presentation. What is the approach for diabetic patient with hyperglycemia coming for emergent surgeries? Number 2, why should nasogastric tube be avoided in diabetic patient? I will open it up to panelist Papicho or Ndaba or Victoria or Mohammed. please unmute yourself and respond to the question.
Hello, Dr. Sweetbet.
Hello, Ndaba, you are welcome. You can continue.
Yes, I think just before I make a comment on the two questions that have been asked, I think Kelvin's hand is up. Maybe he would like to attempt to respond to the question, or he wants to make a contribution. Then I'll come in to make a contribution to the questions.
Please, Kevin, unmute yourself, then continue.
Thanks for the presentation. I just wanted to find out what is the current update on the use of the medications, because some of these patients come with oral hypoglycemics, others come in some are on insulin. It could be intermediate or short acting or long acting. Yeah, thank you.
Thank you very much. Our panelists will respond to that one. So Ndaba, can please continue.
Okay, thank you so much. I think clearly we've learned from the presentation that a diabetic patient coming for surgery is a special patient on our list who has special needs and needs a special attention. So I think like the presentation has clearly outlined some of the principles in terms of detailed pre-assessment, optimization of both the hyperglycemia as well as some of the complications, and making sure that the patient is safe for surgery. I think those are actually very, 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 very important. And so there are so many different, guidelines, approaches, and protocols that people have adopted, in different institutions with respect to the care of a diabetic patient in theater. So to state that there's one standard guideline that applies across the board might not cover everyone in our facilities. So we have different protocols that exist on how a patient who is on insulin should be managed intraoperatively or perioperatively, and some of the different drugs that should be adjusted. The use of the GIK, the Alberti regime is also another option, and how you revise the oral hypoglycemics for those patients that are taking oral hypoglycemics preoperatively versus the sugar control as well. Is the patient hyperglycemic at the time of surgery? How has the sugar been controlled? I think there are so many factors that come into play that might dictate what kind of approach or treatment method that you want to institute. But all in all, I think we always want to stick to basic principles, which we always say that you never go wrong. Basic principles means that, first of all, you want to make sure that you get a very good preoperative assessment and understanding the glycemic background of the patient. You also assess for those complications. And then you also want to make sure that you understand what kind of regimen the patient is taking, as well as the duration of surgery. Is it minor surgery? The timings that the surgery is going to, take. And I know that we always recommend that these patients are operated on, they should be the first on the list, because all that is done to sort of try and avoid complications, try and avoid some of the, risks that may arise as a result of prolonged starvation, etc., etc. So there are so many factors that really come into play. Some of those will impact on how you are going to plan your diabetic care intra-op. And so to mention that every patient who comes in on insulin, you have to start the GIK regime. That might not apply in all settings for all patients. And so the presenter concluded by saying that, this patient should be managed on an individualized basis or case-by-case basis, because there are so many factors that would come into play. However, for us, the understanding that we've got different options for managing these patients, I think that's also very, very important. So maybe I would invite one of my colleagues to add to that my contribution. Thank you, the moderator.
Thank you very much, Ndaba, for your contribution and the response. We'll open the room for Papicho if he has something to say, but also as he is preparing himself, I will. There are another two questions, which I think this one goes to Victoria. I need your advice. I need your advice regarding oral hyperglycemic drug in black tea metformin. What do you think about bridging it with the therapy? So perioperative management for a patient coming in with metformin. So I think after Papicho, if you ask any comment, then Victoria, you will respond to this one.
Okay.
Thank you very much, Dr. Feedback. I think on that question, Dr. Daba elaborated more. I don't think that there's much to add. Maybe just to say hospitals or universities now are now having their own protocols which they think is working better for them. So if you as an institution, you have a protocol that is working, you can apply it better. If you don't have, then we can still share the protocol that we use for this presentation. We can share the link of the article, and then people can rely on that one so that they can use for their practice.
Okay, thank you, Papicho. So, Victoria?
Okay.
Metformin and the perioperative?
Okay, so I think some may be delayed joining, but we discussed on optimization of oral hypoglycemics. I just, there are updated guidelines regarding optimization of oral hypoglycemics. I believe this document will be shared with everyone, but just on metformin, sulfonylurea and SGLT2 inhibitors. Previously, metformin, we used to omit metformin on the day of surgery. And the reason was because it was associated with a higher risk of acidosis. But it has been shown that that risk of acidosis is not as high as we thought it was. And so currently, the current guidelines do recommend that when a patient comes and they are on metformin, they will continue with their drugs and they'll continue as normal, even in the morning of surgery. That is metformin. That is the current recommendation. Sulfonylurea, like glibenclamide, which is also a very common drug. If a patient is coming for surgery in the morning, these ones we do omit sulfonylureas. So metformin continues, but sulfonylureas like glibenclamide are omitted. SGLT2 like dapagliflozin, these ones we do omit completely. And actually, we do not take them on the day of surgery. Actually, I think it should be discontinued 2 to 3 days prior to surgery. I think we will share this document with everyone. There are all the drugs here. Dr. Sweetbet.
Yes, thank you very much, Victoria. So actually, basically, the modification, most of this drug, apart from the complication she just said, it also interference with the eating and drinking. So if you are taking a patient through the LS, if you are, for example, someone comes in, you are giving you're doing your regional anesthesia, where they will recover to their normal life in the next 3 to 4 hours. Most of the time we don't need to change these drugs. So I quite agree with you. They are modification, but also type of surgery and the type of anesthesia might also influence your modification. So there's another question which I think this goes to Mohammed, if possible, or any can reply. So the question is, how should the GIK infusion be administered? I think this person missed it when we discussed it in the presentation. So he's asking about the standard rate and the titration to the effect of the GIK infusion, and also he wants us to comment on managing pediatric diabetic patients. So Mohammed, if you are available, please unmute yourself. Or Papicho or Victoria, anyone, please. The floor is yours. Victoria, can you proceed if Mohammed is not?
Okay. I'll answer the glucose insulin, the GIK solution. So in the presentation, we had said that glucose, insulin, and potassium will be added together in the same solution. So if you have it's called an Albert regimen. So if you have 500 mils, if you have 10% dextrose, so you take the 500 mils of 10% dextrose and then add 16 international units of insoluble insulin, and also add 20 milliequivalent of potassium. So there are rates to which you can start with, and the rates will really depend on the level of blood sugar that you have currently. And so there is no a straight answer of saying that we shall start with, let's say, 60 mils per hour or 100 mils per hour. I think we can share that as well. It's like a sliding scale. When let's say blood sugar is less than 4, you stop the infusion altogether. When the blood sugar is at a certain level, you increase the infusion. When it is at a certain level, you either add potassium or you remove potassium. There is a scale for that. So it's not a one-way answer. It's just that you need to know what is in your infusion and what blood glucose the patient has in that particular time, electrolytes as well.
Okay, thank you very much. Annington asking about the link. Yes, the webinar is recorded and will be shared on the Gladian website on the e-learning platform. So that will be, you can access it at your own time. So someone is asking about if you can share it in the email. So we'll come back to you, Lucy. And I think we have answered all of the questions. So we'll open up maybe 1 minute for one last question. If there's any burning issue from participant. Hello, if the so I'm looking if there's we haven't
From Daniel.
Daniel, please. How comes I can't see?
Okay, thank you for your presentation. Am I audible?
Yes, continue.
Okay, all right. Thanks for the presentation. I just wanted to find out what it's about the glycated hemoglobin. What's the acceptable for an elective surgery? Although when you presented, it was like glycated hemoglobin, it's not really considered. Why I ask this is if you have a diabetic, even if let's say the fasting blood sugar is 12, and then you have the glycated hemoglobin of 15% for an elective surgery, are you going ahead, despite the fact that the fasting glucose is within an acceptable limit, but the glycated is very high? Would you proceed or would you defer, especially for an elective surgery? So again, I ask, is glycated hemoglobin important in perioperative management? Thank you.
Thank you. I think we missed the last part, but I think the question was regarding the HbA1c. It's yours in preoperative setting. So I will take this to either Papicho or Ndaba. Please, can you respond? Or Mohammed?
Okay, I'll start up and then Elon can come up and say, thank you very much for that question. Usually, first of all, there are very few places where the HbA1c can be done. Okay, so many patients would come, we focus mostly on the glucose level which you would like to control, because that is the first, or maybe the only parameter that you are able to read and control. The HbA1c is also used where available, and as Lito said earlier on, when it's above a certain figure of 8 milli, there's likely of having microvascular or microvascular complication in that patient. So if that patient is coming for an elective surgery, you can still take time to do further investigation and to see if there's need of optimizing that patient by correcting those other complications that can be in that patient, so that your surgery is safe. Remember, at the end of the day, you want to achieve safe anesthesia, safe surgery. So there will not be any rush to go for an elective surgery. Thank you.
Thank you.
Okay, thank you very much, Papicho. And I think that emphasizes the importance of our clinics, anesthesia clinics. So most of these patients, when you see them on the clinic, you will do almost all of this, and you will optimize. And then when they show up for the surgery, most of this issue will be already taken care. So I think thank you for that, such a good question, reminding us our duty and make sure we do this investigation. Of course, I quite agree. It tells you how the patient is doing for the past 3 months. But also remember, the more the sugar is to the normal range, the better the outcome. So if it's high, you should know if someone was not doing well during that period. And if you want to be well controlled, you should also know the outcome won't be good. So I think we always take care of the glucose at that time, but I think it's also that can tells you how the patient was doing and how he will progress. So thank you very much once again for your time listening, but also for your questions. Actually, I think we have also learned some few things from your questions, and some of the questions which have been responded, some which haven't been responded, like for example, sharing these materials. You will see it in the Guardian website. So I will welcome Mr. Ngajima for closing word, and if you have something to address this audience, please, Ngajima, you are welcome.
Thank you so much, Dr. Sweetbat, for the good moderation on this session. As Dr. Sweetbat said, my name is Ngajima Hashim, Operations Coordinator for Gradient Health System. So I take this opportunity to thank you all for your time to join in our monthly webinar session, because right now webinar session become as a part and parcel of our activities to Gradient. So I hope to see you in the next coming session. In addition to that, all this session, I mean from today and the past session, you can find it in our website. By saying that, I thank you all and I wish you a good evening for those who ending their time, and good morning for those who are starting their day. Thank you all. Goodbye.